have been looking and managing LDL cholesterol and remnant cholesterol for long and quite effectively, but unfortunately the lipoprotein little a remain ignored for quite some time. And we know that this is an atherogenic lipoprotein produced in liver, in which the appropriate component of the LDL is covalently bound to the, by disulfide bound to the ApoA, which is a procoagulant factor. And it is elevated, levels are primarily genetically determined. It easily reflects across the endothelial cells barrier and can cause atherosclerosis. The elevated levels are highly prevalent in the society. We have seen that approximately 1 in 5 people, that means 20% of the global population, that comes to approximately 1.4 billion population, is having LPA level more than 50 milligram. And this is much more than the familial hypercholesterolemia, which is estimated to be around 40 to 45 billion. Now, if you look into the prevalence of this disease in the various parts of the world, in India, in Asian countries, South Asian population, we have 25% of the population having high LPA, as against the Western world of around 15 to 20%. Africa has slightly higher, more than us by 30%. It is an inherited, independent, and causal risk factor of atherosclerotic cardiovascular disease, which has been observed through the epidemiological study, genome-wide association, and Mendelian randomization studies all. That leads to almost 3 to 4-fold increase in myocardial infarction, 3 to 4-fold increase in aortic valve disease, and 1.5 to 2-fold increase in ischemic stroke, heart failure, cardiovascular mortality, and all-cause mortality. The LDL, which has a log linear relation, similarly what we have found, the LPA concentration also has got a log linear relation. So the more the level, more is the chances of having cardiovascular disease, aortic valve disease, ischemic stroke, and heart failure. What we found that the cardiovascular events definitely are linearly related, but when we look into the venous thromboembolism, it has got no relation to high LPA level. Even when the LDL level is well controlled, the elevated LPA level remains associated for the, what we say as the remnant risk factor for cardiovascular disease. So one should estimate LPA level. This has been studied in the AIM-HIGH trial. They have shown that if the LDL levels are down to the target level, but the elevated LPA levels are still high, this leads to increase in cardiovascular risk. What are the mechanisms by which it increases the cardiovascular events? The most important, which we know, is because the LDL component of LPA, it causes atherogenesis because of formation of foam cells, which we all know about that. Since it has got ApoA, so it has got prothrombotic action, and because of the antifibrinolytic action, and also it has got platelet responsiveness also increases by this the protein. The third, the important mechanism is pro-inflammatory mechanism, and it is the oxidized phospholipids which plays a major role. So because of all these three mechanisms, it causes increased cardiovascular events. Largely, this remains stable over time, and hardly any influence is there of dietary and physical activity. And there are many isoforms of Kringle-4 available, but there are few situations we must learn. We should not do LPA level at that time when a patient is having thyroid disorder, because we know that there is a hypothyroidism, the levels are going to decrease. If there is a pregnancy, the levels will it will increase. Menopause, it will increase. If you use HRT, it will increase. The renal diseases are known to increase the levels, and so also the septic condition can cause reduction of the level. Statins are known to increase the level, so also the air pollution. So in those clinical situations, probably one should not do. Once the patient is stable, one should do the LPA concentration. There are a few more informations which have come now recently, that those who have got high lipoprotein level, there is increased chance of developing atrial fibrillation by almost 3%. And this is a recent paper just published in JACC. As we know that aspirin is no more indicated for primary prophylaxis, even in diabetic population. But what they found that this subgroup of people, those who are elderly and those who are having high LPA, and in them, if you give aspirin, possibly there is some role of primary prevention. This is possibly because of its prothrombotic action and possibly platelet activation component of the LPA. We did a small study which published in ES meeting last year on 500 patients, and now we have data of about 1,000 patients. And we have studied the LPA in every patient of atherosclerotic cardiovascular disease, particularly acute coronary syndrome. The levels above 50 milligram was fine. We found much more in younger population than to that of the elderly population. We also found we used the genesis risk score, and we found it is positively related to the severity of cardiovascular disease. And the patients, those who are having associated familial hypercholesterolemia, we found the levels were higher. It is almost 43%. So in general population of atherosclerotic cardiovascular disease, it was 35%. In young was 37%, but in FH population, it was 43%. Now, who should get this test? There's a guidelines which have recommended that every adult once in a lifetime should get this test. If the levels are above 180 milligram, then it is almost equivalent to that of FH population. The other area where we can use these levels are when there is a patient who has got moderate risk of atherosclerotic cardiovascular disease. If the levels are high, he can be changed to a high risk population. Other individuals where we should do this test is a patient of FH, patient those who have got recurrent coronary events in spite of lipid which are well controlled, and there is advice now that if a patient has high LPA with atherosclerotic cardiovascular disease, just like FH, we should do a cascade screening of the family members also, so the siblings and also the children, so that we can identify them early. And regarding the management of LPA, there is no specific treatment at the moment available. So in the absence of that, since we know LPA is a risk modifier, it is a magnifier or amplifier. So what we learned is that if a patient has associated risk factor, that should be aggressively managed. And then only we'll able to reduce the bad effect of the other risk factors. That is for today. But as I said, that statin do not reduce it, statin rather increases the level. Niacin probably has not much of a role. Lipoprotein apheresis played a role. Now, the drugs like PCSK9 inhibitor and inclisiran, which is small interfering double-stranded RNA, these both drugs have shown that they reduce LPA level by almost 25%. But now there are emerging therapies which are specific for lowering the LPA level. They are the novel antisense oligonucleotide and small interfering RNA particles, which they reduce the hepatic synthesis of the LPA particle. We have learned from the subgroup analysis of Fourier and Odyssey trial that if a patient whose LDL levels are at goal, but their LPA levels are high, if you reduce them, there is a reduction of events. So this is one of the first evidence which shows that if you reduce LPA, there is a reduction of cardiovascular events. This is a specific drug, the antisense oligonucleotide, which is being now evaluated in Horizon trial, where we are participating. This is an injectable drug. They have given 20 milligram weekly for 6 months, and there was significant reduction. 80% reduction of LPA level has been seen. The good news is that it is very well accepted. So far, there is not much of side effect which has been seen, except for the injection site reaction. So this drug, probably answer will come by 2024 or 25 to get the final answer whether this pelacarsen will reduce the cardiovascular event or not. So the question comes, how much shall we lower the LPA level? In the absence of randomized clinical trial, the large absolute reduction, probably 50 to 100 milligram, may be required in randomized clinical trial, although we are still not very certain. Horizon trial, which has included patients above 70 milligram of LPA, probably will give us some answer in future for that. So in summary, dear friends, there is a strong evidence and causal association between LPA concentration and outcome in different ethnicity. This association is continuous even at low levels of LDL cholesterol. LPA is a new risk factor for aortic valve disease, just like amyloidosis, and LPA should be measured at least once in adults. A high LPA concentration should be interpreted in contrast with other risk factors. As I say, it is a magnifier or amplifier, so we should reduce it. For example, two people have 100 milligram LDL. The fellow who has got high LPA will behave like 130 because there is a correction of LDL also. And we have learned that statin, the effect of the LDL reduction with statin is slightly resistant in high LPA population. So specific effective LPA lowering therapies are there in phase 2, 3-year trial now, and in future probably we'll get the final answer whether we reduce LPA by pelacarsen or then there will be further reduction of cardiovascular event. Thank you very much for your kind attention.